Hello, I'm Matt Bruins, Chief Therapy Officer in Milwaukee Rehab Hospital, and joining me today is Dr. Knight, our Medical Director of the Milwaukee Rehab Hospital. We are beginning a series of podcasts where we'll be discussing differences of rehabilitation hospitals, the therapies and the benefits that they have. With Dr. Knight, first, can you please set the stage by explaining some of the differences that we have between rehab hospital setting and a skilled nursing unit or other rehab centers?
So it's a good place to start. When patients leave the acute care setting, part of the immediate determination is to decide whether they need to go to, if they can't go home, some other level of care. And when it comes to patients who have suffered some debilitating condition that leaves them with lack of function, let's say, they need to go to a rehab facility or what we call a subacute facility. The difference between the two facilities are significant. A skilled nursing facility who's provide rehab care certainly have therapists, typically less therapy time. Typically, they don't necessarily meet as a team together and coordinate the care, and oftentimes there's no rehab doctor. Even though there are sometimes no rehab doctor there, but an inpatient rehab facility is very much different. It's a highly coordinated, team-based environment. Patients are often more complicated in nature in terms of their condition has led to dysfunction in multiple domains. It might be medical domains, it may be some physical domains, it may be some cognitive, emotional domains. But because of the complexity of their care, they need a facility where a rehab doctor is there, a rehab nurse is there. There's a team-based approach to tackling the patient's rehab issues. Typically, the patients receive at least three hours of therapy a day. It doesn't have to be 3 hours, at least 3 hours of therapy a day. And that's a mandated time. And, as we look at outcomes between skilled facilities or subacute facilities and inpatient rehab, certainly there are certain patients who do well equally. But for a certain set of patients, they do much better in that inpatient rehab setting with a coordinated team led by a rehab doctor, assisted by rehab nurses.
Excellent. That's a lot of information. So if I was to take away a couple of the biggest things that might stand alone, I would say the common folk doesn't really understand the difference between an IRF and a SNF. What would be maybe the two biggest takeaways of the levels of care that separates the two? I know you touched on some of them, but what might be the biggest differences?
The main difference is the coordinated rehab team led by a rehab doctor, and that is a significant difference. They may do that at some facilities, but in a rehab hospital, that's always present. And then the time of therapy that we are in the rehab facility, each patient is given at least 3 hours of therapy, 5 days a week, sometimes more, but never less. So those are two major differences. And one other difference is usually the ratio of the support staff, nursing staff, and CNAs to the patient. The ratio is definitely more generous in the rehab setting than it is in the subacute or nursing home setting.
Yeah, it's ironic that the skilled nursing facility isn't required to have as many nurses as inpatient rehab. Any ideas maybe on why that is?
The patients who go to skilled facilities might determine that they are not able to tolerate the full 3 hours of therapy a day, so they need less of it. Is that in skilled facilities, there's less reimbursement. Our reimbursement is suited towards the facility, and that reimbursement tends to be somewhat less in skilled facilities. So you have different ratios of nurses than there are in rehab hospitals. But so I think that, I mean, it's probably just two. The economics is one big reason, but the other reason is really that the patient type, since they require less intensive care, tend to get less nursing care.
To kind of clarify that a little bit, so one of the differences between skilled nursing facilities and inpatient rehab is that skilled nursing facilities are required to have one RN on each shift, versus in a inpatient rehab facility, a requirement is having on-duty registered nurses 24 hours a day. And that would speak to that complexity that you're talking about, with medical conditions that are required and cared for in an inpatient rehab facility setting. Dr. Knight, talking about, I'm sorry.
I was going to say another point to make is that sometimes we talk about the key players in the rehab team. It's the nursing staff, usually therapists, but there are a lot other staff in the rehab team that makes it that it wouldn't work without them. The ratio of patients to a therapist is also different for them, and a case manager, it may be one case manager assigned to 50 beds in the skilled facility, whereas that ratio is significantly less in a rehab hospital. So there's more time to attend to some of those most social environmental issues that we need to attend to. The dietitians and nutritionists are present for inpatient rehab and part of the team, and play an important part in almost every case. We have so many people with, who are diabetic or have swallowing issues or have particular nutritional needs. So those minor parts of the team are certainly not minor in the rehab hospital and always present, and they're not present to the same extent as skilled facilities.
That's an excellent point. I think that goes unnoticed too. As in an inpatient rehab hospital, the interdisciplinary team plays a larger role than in any other setting. And some of the key players you just mentioned that really aren't present in a skilled nursing facility is the respiratory therapist, that medical dietitian plays a big role. The other interdisciplinary team members, like the case manager that you said, having a higher role in the discharge planning, which could be a nurse, a social worker, or a therapist, actually. And then, do you want to add anything as far as any of the other practitioners or credentialed physicians that we sometimes ask or bring on to the case? I believe we have a fairly unique setting here in our hospital with internal medicine as well, and there's other credentialed physicians that sometimes be consulted.
Well, I could talk about that in terms of, the patients we get are more and more complex. I mean, they are approaching hospital level. I've been doing this for a long time, and I certainly remember managing those patients on the acute side. Now those same patients with the same acute care needs are being managed in the rehab setting. So it's expected in this setting for us to be able to deliver that level of care and still get them to rehabilitate at the same time. So having other specialists around is important, and certainly internal medicine is important because they could help manage the many complex medical issues, while the rehab doctor or rehab staff, other specialists involved like psychologists and wound care specialists, nephrologists and cardiologists, those team players are more likely to be present in an acute rehab setting than they are in a nursing home facility. Or at least if they are there, be there more regularly for a longer period of time. In our hospital, we have a co-management model where internal medicine and PM&R is managed out of every single patient. Every facility, rehab institution doesn't necessarily have that same model, but that model is a good model because it really allows some individual specialized focus on certain problems and not have one's attention be spread over too many issues in any given day, that we could focus on these issues more completely.
Excellent. Dr. Knight, what type of conditions do you feel are usually treated in a rehab hospital? And are we seeing any more of some versus others?
So, any condition that leads to a loss of function, and when I say function, I mean the ability to do things that you usually do: walk, eat, groom, bathe, work, recreate. Anything that leads to a loss of those functions could require you to need rehab. But there are some very obvious ones that comes to mind immediately. Patients who have neurological conditions like strokes, Parkinson's, MS, acquired neurological issues like spinal cord injury and brain injury. Those patients certainly make up a significant part of our patient population. Those with orthopedic issues, whether it be hip fractures or other long bone fractures that limit weight bearing or significantly impair the use of a limb, and those patients typically end up in inpatient rehab. Amputees, which represent a dramatic change in the way that these patients go about their day, having lost a limb. They have to think about everything they do and how to do it differently. Those patients often end up in an inpatient rehab setting, even though there are less of them than there used to be. And then there's just about a third of our patients are perhaps just folks who live in their lives until something very nonspecific happened. They got pneumonia, or they got a really bad infection or respiratory failure. And they end up in a hospital for a long time, we become very weak and deconditioned and develop muscle atrophy. And those patients, particularly if they're in the elderly class, then require our inpatient rehab services as well. So about a third of our patients are orthopedic, about a third of them are neurological, and about a third of them are about deconditioning, disuse myopathy results or prolonged hospital stays.
Okay. Excellent. Thank you. So Dr. Knight, let's say I have a loved one that's sick and very sick, spends a lot of time in the hospital and is just looking to get out of the whole atmosphere of being sick and the whole hospital atmosphere, just wants to get home. Why not just go home with home health care?
Well, I would think home health care is an excellent choice for anyone who is able to do so. If you're not able to do so, and you go home and find yourself not being able to get out of bed, for instance, you're likely, without skilled, trained people to help you, you're likely to stay in bed even longer. And that staying in bed, instead of making you better, will probably make you worse. So we encourage you just to be in a place where you could have enough help to, for the minimum, be able to get out of bed and get your activities done. But the other part of that is that there's no other time where you're going to have such a group of dedicated professionals who are all in one place, specifically tailored to you to help you to gain some function that you have lost. That's a very unique setting. You can never replace that at home or anywhere else, where you have 4 or 5 or 6 people looking at you in a way to figure out what's your limiting factor and how can we fix it in the most expeditious way. And so when you do get home and you thrive rather than just get home and continue to fail. So I would tell that person, let's examine things really carefully. Let's understand who is at home with you, what kind of home do you live in, what do you need to do when you get there, and can you honestly think you could do these things with the help you have? And if you don't, I'll try to help them understand why further medical management is necessary and why we need the people we need to make sure they could do the things they need to do to thrive at home.